Hi, I'm Marvin Bergsneider, and thank you for joining us on this webinar. And today I'd like to talk about pituitary tumors and give you an introduction about pituitary tumors and some of the exciting new treatments that are now available for physicians to treat pituitary tumors. I'm a professor here at UCLA, and I head the Pituitary Tumor Program. I invite you to join this conversation on Twitter at the hashtag, there you see it, UCLAMDChat. So I just want to start off with just a real brief explanation of about pituitary tumors. Pituitary tumors are also called pituitary adenomas. So we use those terms interchangeably. Like any tumor in the body, we talk about pituitary tumors because they come from cells from the pituitary gland. Just like liver tumors come from liver cells, these come from the pituitary gland. Where is the pituitary gland? Well, if you were to take some object, which I'm sure your child has, and place it up their nose, it's right in the back of the nose. And you see here in the circle where the pituitary tumor is, the eyes are back here, and it's deep, almost in the middle of the skull. In terms of its anatomy and the relative anatomy of where the pituitary gland sits, I think the most important thing to understand is that it sits just below the optic nerves. And where the optic nerves cross is called the chiasm. And you can see the arrow right there. And as pituitary tumors grow, what happens is they can push up on the chiasm and cause visual problems, and we'll talk about that in a little bit. So one thing that's nice about pituitary tumors is that they're almost always benign, and it's very, very rare that we see patients with the pituitary carcinoma, which is the cancer of the pituitary gland. So you can rest assured that if you have a pituitary tumor, it's almost always benign. But the effects of a pituitary tumor can be quite serious, including, I mentioned, the visual loss. But if the pituitary tumor is secreting certain hormones, it can cause problems in your body that can lead to very, very serious consequences. So even though the tumor itself behaves benignly, the hormones it produces can be very, very serious. When we talk about prevalence of pituitary tumors or how often they occur in the public, there's a couple of different considerations. You may read on the internet that 1 in 5 people have pituitary tumors. That comes from studies of autopsy studies, generally older patients, and when the pathologist dissects the pituitary gland, they can find tiny, what we call microscopic pituitary tumors that really aren't of any significance. So that 1 in 5 figure is really misleading. When they looked at large populations who just had MRI scans of the brain and seen how many incidental pituitary tumors they find, it turns out there's about 1 in 1,000 pituitary tumors discovered in this way, and that kind of correlates with what we've seen in the general population. They occur by chance, so cases of what we call familial pituitary tumors are quite rare. So if you have one and you have children, there's a very, very low probability, almost none, that you're going to pass it on to your child. So what does the pituitary gland do? Many people refer to it as the master hormone gland of the body. And hormones are chemical signals that are made by the body, in this particular case, by the pituitary gland, that circulate in the blood, and that's what classifies them as hormones. Hormones then affect different tissues or organs in the body. The pituitary releases hormones, and then many of the hormones that the pituitary releases actually go to different organs or other glands in your body that make other hormones, and that's why it's called the master gland. How are pituitary tumors discovered? Well, as I mentioned, some pituitary tumors secrete an excess amount of a certain type of hormone. And if they do so, it's those chemical effects on your body that leads to the discovery of the pituitary tumor. In other cases, a pituitary tumor can grow quite large in size, and then it can start affecting the tissues around it. If it grows upward towards the optic nerves, it can cause visual loss, and people can actually lose their peripheral vision. If it compresses the normal gland, then you start losing function of the normal gland, and you can have hormonal effects due to that. You could have a combination of above. If you have hormonal effects and a large tumor, you can have visual loss, you can have an excess of certain hormones, and a diminishment of certain other key hormones. And then the fourth way is that in some cases you get an MRI scan or a CAT scan for some unrelated reason, and we have an incidental discovery of a pituitary tumor. So pituitary tumors come in all sizes. And here's a MRI scan. An MRI scan takes slices to the body, and this is a slice right down the middle of the head. The nose is here, the forehead, the top of the head, and the arrow is showing the area of where the normal pituitary gland sits. And the optic nerve, you can barely see it, is aligned right above the pituitary gland. Now, if you have a small pituitary tumor, this is called a microadenoma. And it's sort of an arbitrary designation. Anything less than 10 millimeters is called a microadenoma. And 10 millimeters is about half the size of a dime, shown there. And on this image, the arrow is pointing to the darker gray area of where the microadenoma is situated. And the wider area, kind of like a sickle shape above it, is the normal gland stretched over the top of this pituitary tumor. Now here's a macroadenoma that's larger than 10 millimeters, and you can see it's a much, much larger tumor. And where the optic nerve used to be is now elevated and compressed, and the normal gland is this very thin line of white surrounding the tumor. So you can see how an enlargement of the tumor can compress the gland, and you can get failure of the normal gland. And as I mentioned, the optic chiasm, where the optic nerves crossed, are severely compressed in this patient. So I want to now switch gears a little bit, and I'll talk about some of the more commonly affected hormones that are related to pituitary tumors. I'm going to talk about the normal function of these hormones, and then as you can see, once you understand the normal function, then when you have an excess of the hormone, then you get other effects that many are unwanted. So this is just a partial list of the types of hormones that the pituitary tumor makes. And I'm not going to discuss each one of these because each one of these hormones could be a webinar in itself. But if you take just general classes of pituitary hormones, the top two, LH and FSH, and we refer to them in these abbreviations, are sort of the sex hormones. They're involved with reproduction, and as you can see, they're involved with making of the sex hormones or sperm production or ovulation. The next hormone, TSH, stimulates your thyroid gland to release thyroid. Prolactin is a hormone that is important at the end of pregnancy, involved with breast milk production. Growth hormone is kind of obvious what it does. You see it's involved with muscle and bone growth. ACTH is a critical hormone. It tells your adrenal glands to make a hormone called cortisol. And then we have other hormones made by the posterior pituitary gland, ADH, which affects your water balance, and oxytocin, which some of you may know from your reading, is called the love hormone, that when you're in love, your oxytocin levels go up. It's involved with contraction of the uterus after childbirth. And we're not going to talk too much about that because it really isn't affected with pituitary tumors. The three hormones that I'd like to concentrate on today, because they're the most commonly ones affected with oversecretion of hormones, are prolactin, growth hormone, and ACTH. So prolactin, you may know that the word to lactate means to make milk. Prolactin is the hormone that stimulates the breast to make milk. And at the end of pregnancy, when estrogen levels are high and you have prolactin, a mother's breast gland starts getting ready for childbirth, and after childbirth, this allows her to feed her child. So one of the main functions of prolactin is breast milk production. But nature also doesn't want a new mother to get pregnant again. So while a mother is breastfeeding her child, during that duration of weeks to months, typically a mother doesn't have menstrual periods. And that's because prolactin decreases the amount of sex hormones that are released by the pituitary gland and stops menstrual periods during breastfeeding. Prolactin is, the release of prolactin is regulated by a chemical released by the brain called dopamine. And as dopamine is released by the brain, it actually shuts down the release of prolactin. So when your body needs more prolactin, less dopamine is released. So if you have an excess of prolactin that is produced, so what happens in a female is essentially the female body thinks that they just had a baby and they're not going to have menstrual periods, and sometimes they even have breast milk production. Now, for a male who's never had a menstrual period, they never know if they were missing that. And only the second effect, the decrease of the sex hormones occurs, and they can have low testosterone. And unfortunately, that isn't clinically evident, or people don't go see their doctors about that, or even if they do and a low testosterone is found, a prolactin level isn't drawn. So it is important if you're a male with low testosterone to ask your doctor to get your prolactin levels drawn, because in some cases they're going to find a pituitary tumor, and that's something that can be fixed if it's discovered early on. So a pituitary tumor that produces prolactin is called a prolactinoma. And when it secretes an excess amount of that hormone, it causes those problems. And this picture here, we see that the arrow points to this dark area. The normal gland is more in white, and the dark area here is a prolactinoma that's fairly small in size. It'd be a microadenoma. So I mentioned that dopamine is the chemical that shuts down prolactin release. So there is a medication called cabergoline that acts just like dopamine. It acts on certain receptors that only respond pretty much in the pituitary gland, and it shuts down the production of prolactin. And when it does that, for many, many patients, the tumor shrinks away. In about a third of patients, they can be cured just with this hormonal therapy. It's not a chemotherapy. It's actually pretty well tolerated, and most patients don't require surgery if you have a prolactinoma. But in about a third of patients, they can't tolerate it, or it doesn't work well. And so I still do operate on patients with prolactinomas, but like I said, fortunately, if you have a prolactinoma, you have a very, very good medical therapy for it. There are other options if medical therapy and surgical therapy doesn't work, including radiation therapy, and I'll talk about that a little bit later. So the second hormone I'd like to talk about, and it's the second most common, prolactinomas are the most common hormone-secreting tumors, are growth hormone-secreting tumors. Now, growth hormone, you're all probably well aware of. The professional baseball players are often caught doping growth hormone because it really adds to their muscle bulk. Whether it adds to their strength or performance is unknown. But what growth hormone does in the body, it itself is a pituitary hormone that has direct effects on muscle and on bone, but it also stimulates special cells in the liver to make a hormone called IGF-1. It's insulin-like growth factor, and both growth hormone and IGF-1 then circulate in the bloodstream and affect bone growth and muscle maintenance and muscle growth. So when a child is going through puberty and in their growth spurt, a lot of growth hormone and IGF-1 is circulating, and during that time, that's when they grow. When you have an excess of growth hormone produced by the pituitary tumor, if you haven't stopped growing yet, you get gigantism. And here's a picture of a pituitary giant. This gentleman had a pituitary tumor, and you can see just how tall he became. He was over 8 feet. Many pituitary giants are 7 feet or over. Andre the Giant, the movie star, is a pituitary giant. He had a pituitary tumor. If you've already stopped growing and then you develop a pituitary tumor, you develop a slightly different condition called acromegaly. And acromegaly literally means growth of your limbs or of your tissues. So you no longer become taller, but you have many of the same physical features that the giants have. And here are some of them. So as I mentioned, acromegaly is abnormal growth of the hands and feet. If you're an adult and your shoe size keeps getting bigger and bigger and bigger, you should go see your doctor to make sure that you don't have acromegaly. If your wedding ring no longer fits and you have to keep resizing your wedding ring. And so this picture here is my hand. That's a picture of my hand next to an acromegalic hand. And you can see just how large these hands can become. And it's a diagnosis that you can make sometimes with a handshake. It's like shaking hands with a soft dough of bread hasn't been cooked yet, that the hands are very doughy and mushy. It can also affect the facial appearance and not in flattering ways. Many of the facial changes almost looks like you're become a Neanderthal type. You have the ridges above your eyebrows become very prominent. Your nose becomes prominent. The cheek can become very large and the jaws become large. You see this gentleman here has many of the features. The teeth spaces, because when the jaw gets larger, the teeth spread apart. The tongue can become very large, and many different organs can enlarge, which cause problems. Because the soft tissues in the back of your throat enlarge, your voice becomes low. And if you listen to Andre the Giant in the movies that he's been on, he has a very, very low voice, and that's caused by the acromegaly changes. Because of these extra soft tissues, you can also get sleep apnea. And this is one way that it's diagnosed through people who develop sleep apnea, that you should be screened for acromegaly. If you have too much tissue in your wrist area, you can get something called carpal tunnel syndrome, and you get pain in your thumb and the side of your hand here with repetitive motions. It also enlarges the heart. And when the heart gets enlarged, it doesn't pump efficiently, and patients with acromegaly can develop heart failure. And it can be quite serious, and actually untreated, patients with acromegaly have a shortened lifespan. And unfortunately, many acromegalic giants, or pituitary giants, don't live much beyond 50. What is the treatment for acromegaly? Well, if the tumor can be removed surgically, if it's a nice surgical candidate, the best treatment is surgery. There are medications, and I'll mention them a little bit later, that are becoming more and more effective. And we commonly use a combination of surgery and medications to treat this, because it's so important that we achieve a cure for acromegaly. And then as sort of a third line therapy or last resort, we can resort to radiation therapy if surgery is not an option or if you're not responding to medications. Now, the third pituitary tumor I'd like to then discuss is cortisol. Cortisol is a stress hormone. Its production is stimulated by ACTH, which is released by the pituitary gland. And this is a hormone that if you're in a very stressful situation, if you're being robbed, the pituitary gland produces ACTH, which releases cortisol, and it releases epinephrine, also known as adrenaline. It allows you to run away, or what we call the fight or flight. If you have an excess, you get something called Cushing's disease, and I'll explain what that is. So Cushing's disease is a really debilitating disorder. The main thing that it causes is obesity. And in America and other countries where obesity is becoming more and more common, it's increasingly difficult to distinguish who has just plain obesity for other reasons versus Cushing's disease. The obesity is mainly around the trunk, and you can see this patient, her legs aren't, at least the bottom part, aren't that obese. It's mainly what we call truncal obesity, and they get those purple stretch marks on their abdomen, which are different than stretch marks from after pregnancy, which aren't purple. There's many changes in the face, rounding of the face. It becomes reddish, more acne on your face. And patients with Cushing's disease can also develop diabetes mellitus, sugar diabetes, which can be very difficult to treat because of the cortisol. They can develop very high blood pressure and also have very, very difficult to treat blood pressure. The muscles don't like cortisol in high levels, and so you get muscle weakness, and so very athletic people can no longer even do a deep knee bend because of the muscle weakness. Another finding is easy bruising, and if you have a lot of bruising on your skin and you got weight gain and some of these findings, you should ask your doctor about Cushing's disease. And like acromegaly, if untreated, it's often fatal because of the effects of the diabetes and the high blood pressure and the effects on the other organs of your body. Now, it's difficult to diagnose Cushing's disease. Most patients, by the time they actually had the onset of symptoms and diagnosis, it's 8 to 9 years because they don't go see their doctor, or even their doctor misses it because even in endocrinologist's hands, it's a difficult diagnosis to make. But a lot of it is if you bring it to your doctor's attention and if you see the right doctor, then you can make the diagnosis earlier. The best treatment for this is surgery, and these are typically very small microadenomas, and if we can find them and remove them, you can be cured. There are medications that can be used to block the cortisol production by the adrenal glands and sort of treat the symptoms, but doesn't really directly treat the pituitary tumor. There are newer medications now that have some promise on treating the direct production of ACTH. And in some cases, radiation therapy is needed. And there are other surgical options, including sometimes removing the adrenal glands to stop the production of cortisol. So those are the hormone-producing tumors. Now, I'm going to just mention now the large pituitary tumors, which can be hormone-producing as well. These cause loss of vision and hormone deficiencies rather than excess hormone problems. So this is sort of a description of what you might get if you have a visual problem with a pituitary tumor. On the top is what you might see, the normal view of the White House, and on the bottom, you basically have lost your peripheral vision. You can only see what's in front of you, and you can't see what's on the side. And this can be quite risky in terms of driving a car. You don't see a pedestrian on your right side, or you don't see someone pulling in from the right side. So this is what you get from optic chiasm compression, called a bitemporal hemianopsia, losing your temporal vision. Now, the pituitary insufficiency there's different hormones that can be affected there. The one that kind of drops out first with pituitary tumor compression are the sex hormones, and then for a male, they come in with low testosterone. For a woman, it may be that they think they went into menopause earlier than they really should have. Hypothyroidism, insufficient thyroid, can then cause fatigue, weight gain, tiredness. Growth hormone deficiency, if you're a child, means that you don't grow and you remain short. And if you're an adult, it has fewer effects but can cause some loss of muscle mass and also just not feeling well. And then cortisol deficiency is the last to go. It's the most robust hormone, and it can cause low blood pressure, and it is serious. You can even die from cortisol deficiency. And here's a showing of severely compressed normal gland. Kind of outlined it there in pink. So what are some of the advances now? And here's where the excitement is, because actually all three treatments of medication, surgery, and radiation have all improved over the last 10 years. So on the medical side, one of the advice that I can give you is that you really should see an endocrinologist. And if it's one of these more complicated pituitary disorders, you may want to see an endocrinologist who specializes in pituitary tumors. They're called neuroendocrinologists or pituitary endocrinologists. This is my colleague, Anthony Heaney here at UCLA, who's a world expert on pituitary tumors. And he is able to, we work together to try to figure out what's the best management for any given patient. I mentioned for prolactinomas that cabergoline is our first round of treatment. For acromegaly, there are several medications, octreotide, lanreotide, that affect the release of growth hormone. Pegnisivant blocks the action of growth hormone at the liver And so between those two medications, about 60% of patients can receive some benefit in normalizing their IGF-1 levels. Cushing's disease, unfortunately, has kind of eluded us in terms of a medical treatment. There are some newer agents that have some promise, but unfortunately, they only work in a very small percentage of patients. So again, I really suggest that you seek out an endocrinologist who specializes in pituitary tumor management, and you can usually typically find those at pituitary centers that specialize in pituitary tumors. I'm a surgeon, and this is where my involvement is in terms of the treatment of pituitary tumors. And probably one of the biggest revolutions that have occurred for pituitary tumor management is the use of the endoscope. And here the endoscope is this device here. It has a little star label on there. It's a device that allows us to shine light and look deep into dark holes. There's a camera sitting right there. And we, as you can see in the lower right-hand corner, are looking at a high-definition television monitor and doing the surgery just like that. This is opposed to what traditional pituitary surgery was and still is in some places, and this is how I learned pituitary surgery, but no longer do it this way, where you have a speculum, you put it down the nose, and this is all that you see. You see a very small area to work. You don't see all what you need to see, and although it can be effective for smaller tumors and some other tumors, really almost every pituitary surgeon now has gone to an endoscopic view, and this is an endoscopic view where you can see all the structures. This is the pituitary tumor right here. If you were using a speculum in the old technique, this is about all that you could see. You couldn't see any of these other structures. And here again, the tumor and the normal gland. And with endoscopic surgery, an experienced surgeon, we can literally just peel the tumor off the normal gland, preserving the function of the normal gland because we can basically see everything. So there's increasing consensus that endoscopic surgery is safer. It allows more complete removal of even larger tumors. And many tumors that previously were considered inoperable either through the nose or in some cases just plain inoperable, we now routinely approach with endoscopic surgery. This is a patient of mine that I saw. This was his pituitary tumor, and he had seen two other surgeons who both recommended that they do a craniotomy, remove the skull here and approach it from underneath the brain to remove this tumor because they thought that it was just too big to approach to the nose. But with endoscopy, this is a pretty straightforward tumor, and you can see here a complete removal after endoscopy. And to do this, you need to work, I think, as a team. So here's my colleague, Marilyn Wong. She's a head and neck surgeon. She specializes in surgery of the nose and sinuses. She's a rhinologist. So we work together, and she takes the initial part of the surgery. We work together for removal of the tumor, and then she takes care of the nose afterwards, which is really important. The healing of the nose is something that must occur in the most benign fashion so you can get back to work and recover faster. And then radiation therapy. This is something that over the last 10, 20 years has really revolutionized radiation therapy. It used to be that you used to stand in front of a radiation machine and they would irradiate through your head, and they'd get your temporal lobes of your brain and your eyes and a lot of deleterious effects of radiation. This machine here rotates over the head, and as it does so, a beam is always pointing at the pituitary tumor, and it allows much more precise radiation, basically just to where the tumor is. And this is kind of like a topography map showing the fall off of radiation doses away from the normal gland. So the other structures, here's the optic nerve outlined here, actually gets a lot less radiation than they used to. So this is really a great technology and a great treatment for patients who can't have surgery or have failed medical treatment. It's sometimes overused, and so we use it as a sort of a last resort here at UCLA. And I just want to close with, it's a team approach. The pituitary gland, because it involves the vision, the hormones, the nose, a neurosurgeon, because it's right below the brain, is best treated with a team of physicians. And that's kind of what a pituitary center is all about. It's a coalition of physicians that come together and work as a team closely to decide what's best for any individual patient. And I'm very fortunate to work with just superb head and neck surgeons who allow me to do very complex operations. I mentioned Dr. Heaney and other neurosurgeons, endocrinologists, radiation doctors, special interventional radiologists, pathologists, and ophthalmologists for the treatment of pituitary tumors. You can get more information about this at our website. It's pituitary.ucla.edu, and we have many different web pages about different topics in pituitary tumor. And again, please join the conversation on Twitter. So, I have some questions that have already come up. So one question, and it's commonly asked, is how did I get a pituitary tumor? And, I know it's a bit glib, but my answer is bad luck. Although, again, it's a benign tumor, and among different types of tumors that you can have, because it's often curable and treatable, it's better luck in that respect. We don't really understand the underlying mechanisms of whether it's radiation or some chemical that you're exposed to or genetic effects that cause pituitary tumors, or maybe all the above. But again, we just don't have enough understanding yet to answer that question. What is endoscopic surgery of pituitary tumors? I think I explained that. So the endoscope is a tube, a glass surrounded by a sheath that allows us to go into areas of the body. Many people have laparoscopic removal of their gallbladders. That is an endoscopic procedure. And so it belongs in that group of surgeries that we classify as minimally invasive, because we no longer have to make large incisions because we have such great illumination and visualization with the endoscope. When you remove a pituitary tumor, is the pituitary gland removed at the same time? Well, that's clearly not our goal. Unfortunately, the pituitary gland can be damaged during pituitary surgery, and that happens in about 2 to 3% of cases. It's typically very large pituitary tumors in which the gland is very, very thin, and it's just unavoidable to injure the gland. But for the most part, the gland function remains intact and even sometimes improved. My doctor tells me that my testosterone my low testosterone might be caused by a pituitary tumor. Can you explain why? So there's sort of two mechanisms for a male with low testosterone related to a pituitary tumor. Either a large tumor that's compressing the normal gland, or an elevated prolactin level which diminishes the secretion of the sex hormones, and then telling the testes to make testosterone. So if you have a large prolactinoma and you're a male, you have a double whammy. You have two different reasons why the testosterone can be low, and some of these patients have extraordinarily low testosterone levels. After removing the pituitary tumor through my nose, will I still be able to breathe through my nose? Well, it depends just how much surgery we have to do. In many cases, you still can breathe, but you're going to be congested for the first day or two, and then it quickly gets better. If you have sleep apnea beforehand, we can put a tube in your nose at the time when you wake up, so it allows you to breathe afterwards. So for some patients, the answer is yes, that you may not be able to breathe through your nose for a couple of days. I've heard that gamma knife radiation can cure my pituitary tumor without the need for surgery. Is that true? So gamma knife is a brand name of a technology similar to what I showed before in terms of that, what we call beam-shaped radiation therapy or stereotactic radiosurgery. In general, radiation therapy is very good at controlling tumor growth. How it affects the hormone levels. So if you have a hormone-producing tumor that's over-secreting, for example, growth hormone, the effects of radiation first take many, many months to years sometimes, And you clearly don't get the same type of response you can get with surgery or radiation. So as I said, that we typically resort to the last resort for radiation. Is a head and neck surgeon always needed for endoscopic surgery? And the answer is no. I prefer to always work with a head and neck surgeon because, again, they are the nose specialist. They really take care of my patient's nose during surgery, after surgery, and that can actually be a cause of a lot of anguish and suffering if your nose doesn't heal well after pituitary surgery. But I know there are some surgeons who choose not to use a head and neck surgeon, and we sometimes see some of their patients afterwards, and our head and neck surgeons have to go in there and try to fix some of the scarring and all that that's occurred. So I think it's the ideal case, but not necessary for every pituitary tumor. Are there new or experimental medicines for pituitary tumors? And the answer is yes. Usually any experimental trial you're going to find at a university center where you have a pituitary program and a pituitary endocrinologist who's heading that. We have many at UCLA in terms of experimental trials going on for various types of pituitary tumors, including Cushing's disease and for acromegaly. After surgery, when can I return to work? And that's also a question that's almost always asked. You can return to work part-time in about 2 weeks as long as you don't have to lift anything heavy. We usually tell our patients that around 3 to 3.5 weeks you can return to work full-time and without really too many restrictions. And that's sort of the best estimate in terms of giving your boss of when you're going to go back to work. What can I expect my nose and sinuses to feel like after surgery? Now that varies a lot depending on how they were before surgery. Some people with a history of sinusitis, with chronic congestion, can have more problems than other patients. If you live in a very dry area where you have more prone to nosebleeds, that can also cause more problems. But in general, your nose takes about 2 months, 3 months to completely heal after pituitary surgery. But after about a week or two, your sense of smell starts coming back. Your nose function becomes much more normal. You have less scabbing or what's called crusting. And by a month, most patients are actually doing quite well and quite happy with their nose function. Which ones here? The top ones? Are there any clinical trials for pituitary tumors? Yes, there's actually some exciting new drugs that are being developed, particularly for Cushing's disease and acromegaly. And these are often available, again, at university centers or at defined pituitary centers of excellence, where a pituitary or neuroendocrinologist is heading the program. And again, for Cushing's disease and for acromegaly, there's very good clinical trials. And even for pituitary carcinoma, which I didn't discuss today, there are several medications that are being tried for those very rare patients who have that. How do I manage my pituitary tumor on a daily basis? Well, you manage it with your endocrinologist, and depending on whether you have a hormone excess or a hormone deficiency, then I either have to give you replacement hormones, or we work on a management scheme to either reduce the excess of hormone to a normal level, or remove the tumor surgically or by some other means. But by and large, there's not a lot for you to do to manage it other than to see your endocrinologist, work with your endocrinologist as a partnership to develop a treatment management scheme that's best for you. Can a pituitary tumor go away without treatment? It's rare. Sometimes smaller tumors and the non-hormone producing tumors can remain small, and we just often watch those with yearly MRI scans, and sometimes they never need treatment. It's quite rare, though, to see a pituitary tumor involute and go away without some type of intervention of medication, radiation, or surgery. Does a pituitary tumor affect children differently than adults? So first, pituitary tumors are very uncommon in children. They normally occur in young adulthood and extending all the way to the 60s and 70s. If they are hormonally secreting tumors, there's a couple of issues. So with acromegaly, if you're a child, you develop gigantism. So if both parents are 5'6" and your child is 6'2", and there's no history of tallness in your family, you should really suspect that there's a pituitary tumor causing this abnormal growth. And again, they'll have many other features of acromegaly with that a deep voice, large hands. Pituitary tumors in terms of treatment in children are very different as well, because as a child, there's many different hormonal changes, puberty, growth that have to occur, and they're working very closely with a pediatric endocrinologist to help those stages occur normally are very important. Small children, we've operated on children younger than 10 years old. Their nose development still isn't complete, and there's other factors that we have to take into effect with children. And lastly, we really try to avoid radiation in a child, because the effects of radiation can be for decades afterwards, and so children are definitely treated differently. What is the outlook for people with pituitary gland tumors? Well, overall, it's very good. If you're diagnosed earlier and you get really effective treatment with using a team approach of experts, it can be excellent. Most patients do very, very well with treatment. With surgery, they can go back to work, have basically a normal livelihood, and once their nose heals in a couple of months, they can go scuba diving, skiing, whatever they want. If you have a hormonally secreting tumor or Cushing's disease and all that, there it's so important that we achieve normalcy in the hormones. And once we do that, you can practically go back to a normal life if you haven't had too many of the ill effects of the hormone prior to being treated. And what are the symptoms of pituitary disorders? If you kind of just want to break it down to the basic ones, there's the overproduction of hormones that can cause a variety of different symptoms. There's the underproduction of hormones due to a large tumor compressing the normal gland. And the third symptom that is the most common is visual symptoms of loss of peripheral vision. Thank you. I have a medium-sized pituitary cyst and possibly an adenoma, although it's a questionable on MRI. My blood work is also confusing, but a high IGF-1. Is it possible the cyst is causing the high IGF-1? That's a very difficult and challenging question, particularly if we don't have the values. Typically, cysts aren't related to hormone excess from pituitary tumors. Most pituitary tumors are solid tumors, may have a small cyst associated with it. So the possible adenoma is probably a much more likely explanation that it's releasing growth hormone. That's leading to your increase in IGF-1. What is the average cost of this type of surgery? There's many different costs involved with healthcare. The hospital cost in terms of what it takes to treat a pituitary tumor patient, including the hospital costs, the surgeon's fees, the pathologist's fees, the MRI scans, and all that, are somewhere around $20,000 in terms of what the hospital costs are. Now, How that translates into what a hospital bill is a different equation. The hospital does need to make a profit, and so it may be more than that, but in general, that's the typical cost. All right. Thank you very much for joining me today, and goodbye.